And now Dr. Bussel will move on to our second interactive case.
Okay, thanks, Cindy. Well, this is a 78-year-old male, and he presented to the emergency department with a lot of pain that was nonspecific, and he said to have a low platelet count. This is what we're hearing when he comes to us. And he had been feeling well, but then he had some nonspecific low back pain and some joint pain, which was mainly in his shoulder. He had an episode of hematuria and of epistaxis, which were apparently self-limited. He also thinks that he's been feeling extremely tired of late and denies any additional hematuria or other types of bleeding. So we have to think very carefully about what's going on with this gentleman. If he was younger, we might think that he had lupus or something like that, but a 78-year-old male presenting with that would be unlikely. He's got a history of some other comorbidities, hypertension, type 2 diabetes, and he says he's been thrombocytopenic for a while. He had a left inguinal repair previously without incident, and his labs come back with a hemoglobin that's a little lower than what he's run apparently in the past, a crit just under 30, normal white count, very importantly, a normal MCV. His platelets are 10, his PT, PTT, and INR are all normal. So which of the following tests would you recommend for this patient in addition to what he has? Would you get a DAT, a Brett Coombs test, immunoglobulin levels, an ANA, a bone marrow, or you're not sure what it would be? So, Cindy, I already cheated and commented on the fact that I think lupus is unlikely, but it wouldn't be amazing if he had rheumatoid arthritis. And he could have a number of other things, especially at his age. So it's a little uncertain what's going on. And I don't know what the platelet count being low for a while means exactly, other than that it'd be nice to know what's going on.
Yeah, he's definitely a slightly different patient, right? With some things that give you a little bit of pause in terms of that simple diagnostic workup versus needing to do a little bit more of some expanded testing. And we're actually getting quite a nice mix here. A few more popping in. So what we have with most of our results in, so 48, about half of people would say, let's do a bone marrow on him. But we did get a few results coming back in, almost 15 to 20% for both a DAT and an ANA. So a couple people really wanting to make sure that this isn't some other underlying autoimmune process, such as either Evans or lupus. And then about 10% said, let's do some immunoglobulin levels on him. And we had a few people that said, I just don't know. And maybe it's because there might be more than one right selection here, but I'll turn it back over to you.
Yeah, well, I think this is one of those things that doesn't actually happen clinically, where you have to select one test as opposed to, just as you said, Cindy, I think you would probably do multiple tests. But in this case, I think the best option was a bone marrow to make sure that he doesn't have MDS or some other problem like that. And I think Cindy has shown this to you already, and there's a lot of options to look at. And this is a gentleman who would deserve more of those options as opposed to less of them. He probably could benefit from hemolysis labs. At his age, again, quantitative immunoglobulins might be interesting, especially if it was done with an immunoelectrophoresis, to see if he had a monoclonal spike. It turned out his guaiac was positive and his urine had microscopic hematuria, and fortunately the bone marrow was relatively normal. So we know that the platelet count does, to a certain extent, go with the bleeding risk. And these counts as listed might fit younger, healthier patients. But we know in an older patient, as you can see in this slide, there's a greater risk of intracranial and serious hemorrhage when you get above the age of 60, and he's 78. So we would worry in his case about an increased risk of serious bleeding. He said he's fatigued. We're not sure. Could this be mild anemia, maybe combined with iron deficiency because of the bleeding? He's got reduced quality of life. He lives on his own, so we don't know much about his anxiety, but it wouldn't be surprising. And he told us he's had some activity restrictions. We talked about fatigue being very common as part of ITP, and depression can also. We reviewed that fatigue doesn't always correlate with the platelet count, though there's something, and that we would want to think about some of the organic causes in addition to psychological fears and other issues that might actually be driving it. In particular, we think about thyroid, anemia, rage. We talked about those. If there was a reason that he was having higher stress, there's many possibilities here, and it can be really difficult to sort them out in many patients. So if you wanted to assess quality of life in a patient, which one of these do you think you'd find most helpful? The SF-36, SF stands for short form, and it's kind of an across-the-board quality of life scale. FACIT fatigue is a short survey focusing just on fatigue. TH6 looks at thrombocytopenia and quality of life. ITP PAC was developed specifically for ITP and has 36 questions. And then you might not want to use any of these and just rely on talking. Cindy, what do you think? What's your favorite here?
Well, the pediatrician in me would have to say that my favorite is the one designed for children, which is the kit. But I think, in clinical practice, what we really need is something that can easily be done in the office, right? The SF-36, while likely great as a research tool and for being able to be comparative, we really need things that are ITP specific and not so time restrictive, right? Because we know that everybody's busy, but it should be something that can be easily integrated into our clinical care.
But if you like the kit, the ITP PAC is ITP specific for adults.
Right. No, the ITP PAC is the one of these that, for me, satisfies those sort of similar characteristics, right?
Yeah.
And I think, what we might need for research or in a research study is going to be very different than what we just need for clinical care.
There's been an attempt to do an 11-question, quick questionnaire, and it's not clear that satisfies everything. So yeah, I think there needs to be enough detail to it, right, that it becomes meaningful. What did the results come in?
Yeah, so our results are in, and we have some mixed responses. About 70% though for the ITP PAC. We have a few more votes then for the FACIT fatigue, and that is important, understanding fatigue specifically, and then a mix between SF-36, the FACT, and not using any.
I would say there is obviously not a right answer here. On at least the research side, the SF-36 has been used more than any of the others. So this is a no specific right answer. Assessing quality of life with patient-reported outcomes. I'm sure many of you are familiar with those from the cancer world, and that's really important. The SF-36, I like it because of the way it divides up areas. The ITP PAC's very good, but as Cindy said, it's hard to come up with one of these that really is time efficient and covers all the bases. Primary goal of treatment for this patient: maintain a safe, sustained platelet count with minimal toxicity, individualized therapy to come up with the best regimen of long-term corticosteroids, alleviate the joint pain, alleviate the back pain, or I don't know? What would any of you pick for this? Cindy, I know that you've got to be a fan of using long-term corticosteroids. Wasn't that something that the ASH guidelines discussed and was the most emphatic thing that came out of that?
Yes, yes. And, if you talk to patients, they will so clearly tell you how much they hate those steroids, right? And I think we do a disservice by just continuing to tinker with the steroids and go up and go down in response to a platelet count over long-term treatment.
I have to say, though, I took steroids for 6 months for back problems. And when you start steroids, there is kind of an appeal because they fill you with energy. So it's easy to see why some people get hooked.
So we've got our polls in, and 95% agree with the statement that we are trying to maintain a safe platelet count, but with minimal toxicity. So very good.
Yeah, the emphasis, by the way, here is in the word safe and sustained. We didn't say normal. You just want a platelet count that is adequate for your patient. And I don't think it's news to anybody about the short and long-term steroid toxicity data. I think also that that part of the heterogeneity of the disease falls into which patients respond to which treatments, which patients with given treatments have side effects, which ones feel better, all kinds of things. So it's important to really pay attention to what's happening in your patient. And I think Cindy would agree that the guidelines, while they do the best they can with the information available, do not provide you with clear resolution in lots of areas when there just isn't the data there to go with them. And the limited number of randomized controlled trials in ITP that have been conducted have compared treatment to placebo or to standard of care, but not to another therapy. And that's what makes it difficult. So he was admitted because of his history, his low count, and his ongoing bleeding and his age. He got started on IVIG and prednisone, and he did well right away, but then his platelets dropped. So given that he had a very short-lived response to IVIG and prednisone, what would you choose here for this patient? Corticosteroids plus IVIG? Would you try IV anti-D? Would you give him fostamatinib? Would you give him avatrombopag? Or is it not clear what to do? There is, by the way, Cindy, an increased amount of data that's come out, primarily, I would say, from Italy, on management of more elderly patients with ITP. And much to my surprise, it's tended to favor TPO agents because in the beginning, worried a lot about thrombosis in that group. But they don't tolerate steroids well at all. I don't think rituximab is as effective in them and seemed like the most logical choice. And like I say, there have been some surprisingly large studies looking at this. So do you want to tell us the results of the poll?
Yep. The poll shows that 83% would do avatrombopag and 17% would do fostamatinib.
And again, there's nothing wrong with either of those choices. You would just have to see how the patient did. So that was our recommendations. And the patient said, I'd prefer a tablet that I only take once a day and something I don't need to visit my doctor regularly with, as transportation is a problem and I hate getting shots in IV. But I definitely want the treatment to work well, be safe, and not make me feel bad while I take it. So this is somebody who wants the Holy Grail, and there's absolutely nothing wrong with that. But it means you have to monitor it and see what your choice is works. So if he doesn't want sub-Q IM or IV treatment, similar to Cindy's patient, that eliminates some of the options, romoplastin and rituximab. He's definitely at increased risk of bleeding because of his age and because of his GI and GU bleeding, even though they're not major. He's had compliance problems in the past, so he's asking for a pill. You definitely want to go with what he wants to and is willing to do. And similarly, fostamatinib, avatrombopag, eltrombopag, and even an immunosuppressive agent would be eligible, and all of these have been used extensively. This is somebody, based on past compliance, that you would like to pick something he'll respond to so he doesn't get discouraged and not do treatment at all. And that includes minimizing side effects. So this would suggest a TPO agent, and Cindy covered this already, the idea of the dietary requirement, liver problems, and it's easier dealing with one tablet size, since you may know that avatrombopag just gives 20 milligram tablets, and you go from 1 a week to 2 every day. So it's a little easier to not have to worry about which size you're going to use and, oh, I was on one size, but then I have to go to another. He knows there's less experience. There's not a lot of long-term data yet. And there's been a little bit of a suggestion, as Cindy commented on, that there may be a slightly increased risk of thrombosis, though that was with some of the earlier studies more than the more recent one. He's able to be reassured, given that his income is very low, that there are patient assistance programs, that he can monitor his count locally and do a fair amount of video visits, all of which are made easier by knowing that his bone marrow is good. So he started on avatrombopag, and he takes 20 milligrams a day, 5 days a week, and 40 milligrams or 2 tablets twice a week. He comes back in 3 months. He's not bleeding. His platelets are okay, but his fatigue hasn't improved, even though his platelets and hemoglobin are better. His guaiac and his urine are negative. So he, as we pointed out before, and Cindy said, you need to keep retesting. It turns out he's hypothyroid, and putting him on thyroid makes things better for him. So again, you've heard this before, but there are multiple therapeutic strategies. They need to be individualized for the patient. And very important, again, you and the patient could decide on something, but you need to keep monitoring it and be willing to redecide if there's any reason that it's not working out. Maybe your patient isn't doing as well with it as you and he or you and she would like. Maybe your patient is being made nauseous by it, even though very few patients are, et cetera. And I guess we have a Q&A now.
A couple questions that I think are good for discussion points that I know there's a lot of kind of work being done around. One of the questions was regarding TPORAs and when to either taper or discontinue them. So, I know that there's some papers out there on this. There's not really good consensus. So I thought I'd ask what your practice is regarding when to potentially think about tapering or stopping a TPORA.
I think the best data for that has come from some recent studies, one from Francesco Zaya in Italy and another from the group in France. And I think if you can get a patient to a platelet count of 100,000, and if they're there for 2 or 3 months, then that's a good time to taper. I think the consensus is for sure taper slowly and not do it too fast, and see what happens. And sometimes you can be partially successful. So let's say you could cut the dose of whatever it is in half, but not be able to go further, at least right then. Cindy, could I answer the pregnancy question that's in there?
Yep, that was going to be the next one I was going to send your way because, I want to be cautious what we say in chats regarding off-label use and things of that nature that we don't have room for full discussion. So I was actually going to those were the two I wanted to bring up because they're both rather off-label discussions. But I think the pregnancy one is a really good question. While still currently, we'll count this at the foundation of saying that they're not approved in pregnancy. But I think to your point, let's have the discussion because I think this is something that we're learning about.
Well, first I wanted to say that I've known Paul Donovan, who's the questioner, for at least 30 years. So I'm thrilled that by asking this question, this means that you're still active in the area. So that's great. We had an article come out in the New England Journal in August on ITP and pregnancy. And I think the general consensus, again, this is, as Cindy would say, off-label, is that for most of the pregnancy, almost all the pregnancy, keeping the count above 20 or 30 is more than sufficient. So this really more comes up at the time of delivery. And again, the number that's consensus, but not particularly data-driven, is to have a platelet count of 50 for delivery, but 70 to 80 for an epidural anesthesia. And that's again another area that shared decision-making and finding out how important that is to your patient could matter. There's increasing data with the use of TPO in pregnancy. There was a study of 30 patients from China. There was a study that Mark Michel put together that's blood in 2020 with about 15 patients, 17 pregnancies. There's a Romoplastin safety study, and there's one that we just reported with somebody who got called up in Israel to be in the Army. We finished it just before, fortunately, on 40-some patients reviewing the literature. So I think that depends a lot, but my vote at the moment would be that I would think very carefully about using TPO patients when IVIG and steroids are no longer sufficient. Cindy, what did you think about the? Oh, go ahead. I'm sorry.
No. I was just going to say, for me too, I think it is comforting to see this literature come out, right? I think it is giving us a better foothold on being able to use them in those rare circumstances, as you pointed out, where kind of recurrent use of IVIG is not sufficient. And, in my mind, perhaps it's something where, the first trimester is the time to be a little bit more cautious once you're out of that first trimester window into second or third, and even closer to the third trimester delivery time. We can probably be a little bit more comfortable that we're going to be doing the right thing. But I agree with you.
I was excited, by the way, when we reported the Romoplastin pregnancy surveillance program. There were over 70 women who were on Romoplastin just for their ITP when they became pregnant. And it didn't seem that induced anything particularly bad. But as anybody who's read the paper knows, it's a very imperfect data group. But it made me feel a little more encouraged. And fortunately, we usually don't have to treat as aggressively in the first trimester. So should we wrap up here? I think we should.
Yeah, we're just at time. It's really been a pleasure to have you all join us tonight. And I think we're good. I don't see any new kind of questions coming in the chat, and I think we got to most of them. So really good discussion.
Take care, everybody.